Welcome, everyone. We'd be happy to have you put your name in the chat and maybe where you're located, just to let everybody else know who's here.
Hello, 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 hello.
Can you hear us, Sergio? Jane, can you privately message him?
Hello.
Thank you.
Is that okay now?
We hear you.
Okay, we're going to go ahead and get started. It's about 2 past the hour. So welcome, everyone. My name is Sarah Meanyrod, and I am the PBRN coordinator for DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment to go over the housekeeping rules for the webinar. Please add your name and location into the chat so all participants can see who else is attending the webinar. If you've registered for CME credit, you must add your name into the chat so that we can verify your attendance. Additionally, you will need to complete the physician attestation form, which was emailed to you this morning, and the evaluation survey, which will be emailed to you this afternoon. The Let's Talk About DO-Touch or Let's Talk About OMM Research Planning Committee has no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to me, Jane Johnson, or G. Franklin, and we will help you. If you have any questions or comments during the presentation, please feel free to type them into the chat, and please feel free to address each other's questions and comments there as well. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself, and please feel free to turn on your camera if you wish. When contributing to the discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. We will provide you notifications using flashcards from G. Franklin to assist you in keeping track of time. After everyone has had the opportunity to make comments or ask questions, there may be additional time for further discussion. Please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET website, where you will have the opportunity to continue the discussion. Please watch for an email from DO-Touch.NET announcing when the recording and the discussion forum are available. All right. So please help us welcome Dr. Jennifer Belsky, who will be speaking about osteopathic pediatric treatment in cancer supportive care. Dr. Belsky is board certified by the American Board of Pediatrics and serves as Assistant Professor of Pediatrics and Director of the Pediatric Lipoma Program at Riley Children's Hospital, as well as serves as Adjunct Faculty and Clinical Assistant Professor at Marian College of Osteopathic Medicine, both of which are in Indianapolis, Indiana. Dr. Belsky earned her degree at Ohio University Heritage College of Osteopathic Medicine in Athens, Ohio. She also completed her pediatric residency and the Hitchcock-Wilson Pediatric Hematology, Oncology, and BMT Fellowship at Nationwide Children's Hospital in Columbus, Ohio. Dr. Belsky has extensive history working with grant-funded research, in teaching positions, speaking engagements, supervising resident research, and has published numerous articles in peer-reviewed journals. Please help us welcome Dr. Jennifer Belsky.
Thank you so much. Can you see my slides okay and hear me all right?
Yes, ma'am.
Perfect. All right. So as mentioned, I typically go by Jenny. Unless I'm in trouble, then it's Dr. Belsky or Jennifer. But I am a pediatric oncologist by training and am kind of a second life to osteopathic medicine and integrating into my practice. And so was asked to speak here today, and I'll touch a little bit on some of my research and some of the opportunities that I think are out there. I have no relevant financial relationships to disclose. So I always think it's interesting to hear about how DOs in general integrate OMT into their practice. And so I always like to start with how I got, as I call it, sucked back into the osteopathic world. So this is Penelope. She goes by Pena. She is an adorable newborn who unfortunately was born with a very large infantile fibrosarcoma, which is a type of cancer that is typically controlled with surgical resection. But you can see here it was very large and on the side of her face, and it was unresectable due to a lot of encasement of the facial nerve. And so walking through our timeline a little bit, you can see here again, it's very vasculature, it's homogeneous, and it's taking up about a fourth of her face in general. And so we were forced to start chemotherapy. And we started what's called VAC therapy, which involves a chemotherapy agent called vincristine. And unfortunately, one of the main side effects of vincristine, other than it is really good at curing cancer, is it causes chemotherapy-induced constipation. And so unfortunately, about 2 months into her VAC therapy, she started suffering from some pretty impressive constipation, to the point where she actually developed life-threatening pneumatosis in December. So only a few months into her treatment, secondary to the vincristine constipation. And we were unable to give her more chemotherapy on top of her fever, possible surgical intervention, and ICU stay. And so it really brought to light, constipation and on top of all of her chemotherapy side effects is a really big deal. And so we were able to start slowly escalating back up her vincristine, which was necessary to get rid of the facial mass, but unfortunately still came with those side effects. And she was dependent on lactulose by March of that year and unable to stool without it. And so I started brainstorming and thinking to myself, what else can we do for her to help with these symptoms? She's a newborn. There's only so much we can do for constipation. And so I started integrating in some osteopathic manipulative techniques in April. And I'd like to share those results with you. And so you can see here, what I did was end up graphing. So on the x-axis is weeks, and -6, you can see was actually no OMT intervention from -6 to 0 weeks. She was using about 8 to 10 doses of lactulose. I started doing weekly OMT in my clinic. And you can see here the drastic improvement. So we were able to get her off of all of her lactulose and really all interventions from a constipation standpoint while giving her vincristine only with osteopathic medicine. And I did teach parents some home techniques as well. And so this is Benia now. She is actually now 1.5 years old, and she is the cutest little grandma ever for Halloween each year. And so what we did is we ended up publishing her as a case of resolved vincristine-induced constipation with just osteopathic medicine. And it's not that far of a leap to say that without curing her constipation, we wouldn't have been able to cure her cancer. And I think that that's a really important point. Supportive care gets lost on these patients a lot. And you can see here, you can barely even see where her mass was. So our chemotherapy works really well, but without osteopathic medicine, she wouldn't have been able to get that vincristine. And so taking a step back, when I approach my OMM research in general, what really got me started was thinking about common things that happen to my patients. And so headaches are really big, especially for kids undergoing chemotherapy. And all I really have as a standard of care without OMT is medications and fluids. Neither work really all that great for headaches, and I typically end up having to consult neurology. My patients unfortunately have a lot of back pain, anywhere from they have primary tumors in their spines, all the way up to they're lazy and they're laying in bed playing Xbox all day while they get their chemo. I can use medications, I can use massage and physical therapy that we have here. And then lastly, myalgias are really big for my patients. And so again, standard of care without OMT is just medications, massage, and increased activity, which if you've ever tried to get a child undergoing chemotherapy to increase their activity, it is quite a challenge. And so thinking again, what research techniques could we do from an OMT standpoint to see if they work? So in addition to headache medications and fluids, could we do simple suboccipital release on these patients, especially after their lumbar punctures or their intrathecal chemo? For constipation, can we do mesenteric lifts on these patients? Has anyone looked at doing that before? Again, in addition to their medications and their increased activity that they're never going to do, what about a simple mesenteric lift? And then similarly for pain, in addition to our standard of care, what about just some simple techniques? What about FPR? What about anything, any indirect techniques while they're laying in bed getting their chemo that could help with pain? And so when we think about all of these different things, I think to myself, how can we utilize OMT for constipation, peripheral neuropathy, pain, whether that's primary site or referred, which is causing this decreased quality of life? And so I'm a firm believer that I want to know why I'm doing OMT. And so looking at the pathophysiology behind OMT is really important. So I briefly want to go over that with you as well. And so when we look at chemotherapy-induced constipation, and really, this is a fourfold problem. You can see aberrations in substance P at the top left. If you mess with the electrical activity of the gut, you decrease peristalsis. Interstitial cells of Cajal, if you imagine those cilia are typically beating really fast, improving peristalsis. When we paralyze them, we get stagnance. And then aberrations in VIP and nitric oxide, you can imagine they're nice and dilating that blood vessel typically. What happens is we cut them off, and so you have vasoconstriction, leading to decreased blood flow, and in turn, having constipation. And so then brainstorming, we think, okay, what are some techniques that we can do to help with all of these things? And so the next paper that we did was actually demonstrating that, there's no routine management of constipation in, especially our lymphoblastic leukemia patients, which is our most common childhood cancer. And so we published this article in the big pediatric blood and cancer journal that essentially said we need more OMT because the pharmacologic interventions don't work. And when we look at what the pharmacologic interventions are, we look at oral medications, which Colace is not my favorite, Doxena, Miralax. If you've ever tried to have a kid with mucositis, drink Miralax, it's pretty impossible. And then again, that increased activity is just not a very reasonable thing. And so when we look at what's in the literature for osteopathic medicine for constipation, taking away the pediatric oncology part and even taking away pediatrics, just in general, what is in the literature? And so when you comb the literature, there's just 2 small studies. Both of them are pilots. One is a 7-person case report and the other is a 1-person case report with a pretty heterogeneous genus population that is not overly applicable. They did show, you can see on the right, this Bristol stool scale, constipation is typically a 1 or a 2, and then trying to get those more normal stools is a 3 or a 4 on the Bristol. And unfortunately, they had a great showing all the way up to 4, but their patients were all very, very different. So we couldn't really draw any conclusions. So unfortunately, this is all that exists in the literature for constipation and OMM. You may be thinking to yourself, well, this is crazy. We do OMM all the time for constipation and abdominal complaints, but it's not in the literature. No one's writing it up. No one's even writing up these simple pilots of more than 7 patients. And you can look here, March of 2010 and 2017 were the last 2 publications before mine. And so it's a little disheartening, but it's also encouraging that there's so much room in the literature for things like constipation. It's an easy enough thing to do and we're all doing it. So we should be writing about it. Next, if we look at the chemotherapy-induced peripheral neuropathy, again, you can really translate this over to even diabetic peripheral neuropathy. It really starts from a mitochondrial dysfunction and then looking at disruption of that pain mediator receptor relationship. And then you get spontaneous discharge of A and C fibers, which then again, you get your numbness, tingling, burning sensation, which for me is really difficult to tell in children. It's a very difficult symptom to tease out. And so you can imagine in the cancer world, we have really strict guidelines as far as how to treat supportive care measures. And actually for neuropathy, there are no established agents because of a paucity of high quality, consistent research. And so you can imagine, I don't even have research from a pharmacologic agent. What are the chances that anyone has looked at CIPN or chemotherapy-induced peripheral neuropathy in the literature? 2 case reports, again. And so you can see here, the top one looked at carpal tunnel, which was a pilot project, which only had 6 patients. And then way back when actually Dr. Schubach was one of my mentors, looked at type 2 diabetes. And so these are the only 2 trials that actually had randomized kind of pilot patients, and they did find some improvement, but again, they weren't powered. These weren't statistically significant. And so how much weight can we really put into them? And so, when we talk about bridging this research gap, and so, I think all of us are doing a lot of OMT, but we're not writing about it. And it's really difficult to convince our colleagues, especially here in the United States, when MDs especially say, okay, well, where's the literature to support that? And I say, you just have to trust me on it. That doesn't go very far, especially in the oncology field. And so I've done a lot of work is try to figure out how do we bridge this gap? How do we actually convince the world that OMM research is easy to do, it's applicable, and we've been doing this for 100 years. We're just not very good at writing it up. And so I've kind of taken these pieces apart, and I think it really starts with doing high quality evidence-based research in large patient populations. And so rather than just looking at pediatric oncology, we took a step back and we tried to bridge this gap between, yes, it works, and there's absolutely no evidence, because we need to bridge that gap in order to convince the world that OMT works and is something that should be thought about. And so taking that step back, the first thing that we wanted to do is really to quantify how many osteopathic studies in the pediatric population have been done. And so this is a recent publication in Pediatrics from 2020 that I did with a few residents. And you can see here, we're getting better at doing research, right? So back 1960 or so, there was about one study, but you can see over the past, decade or so, since really about 2005, we're getting better. And so we're really only up to 8 to 9 studies. And if you think about all the, especially pediatricians in the world that are doing OMT on a daily basis, this number should be so much higher. The other thing, when we look at this and say, okay, is it just because people don't know about OMT in general? And so we took that one step farther, and we did a publication actually looking at the knowledge and need for osteopathic medicine. And I did this in the pediatric oncology community, and there's a few NICU docs that are about to adapt this study. But I really wanted to prove to the world that, maybe we just don't know a lot about OMT if you're not a DO. So I asked 3 simple questions. Question 1 was, have you heard of osteopathic medicine? Luckily, 100% of our oncologists had, only 50% of our caregivers had, and 0% of our oncology patients had heard of it. So it's pretty disheartening. The next question I said was, how much do you feel like you know about osteopathic medicine? And again, you can see our providers there, 70% said some, no one knew a lot about it. Our caregivers were pretty low. They knew very little to none at all. Our patients didn't know anything about it. So then I asked the last question. Would you want osteopathic medicine available as a treatment option? And everyone for the most part said yes. So after they watched a brief video and a script about what osteopathic medicine was, everyone was on board. So 100% of providers, 100% of caregivers, and all but one patient wanted osteopathic medicine available to them. And that one patient, it was a 9-year-old, and he does not like to be touched when he is sick. I said, that's super reasonable. I don't either. But for the most part, everyone was really excited about it. And so, when we think about what this needs assessment concluded, all of our patients reported a need for better supportive care options. So why not OMT? Why can't OMT be one of those options? Majority of our providers had some to little knowledge of OMT. Majority of our caregivers had little to no knowledge, and our patients had 0 knowledge. But the most important part was, once educated, 100% of our providers, 100% of caregivers, and 95% of patients desired to have osteopathic manipulative therapy as part of their treatment option. And so this was a really landmark study that proved to at least my large children's hospital back when I was at Nationwide Children's in Ohio State, that this is something that deserves attention. This is something that should be a priority. And this is something that we should get research funding for. And so when we talk about, how do we do these studies? Majority of people say, I don't need to do these studies because my clinics are full. And the other thing is, we don't have protected time or funds to do these research projects. And so some research tricks that I've learned is I actually embed a lot of my osteopathic aims into my larger research plans. And so, for example, chemotherapy-induced constipation is a larger part of a chemotherapy side effect profile. And so what I do is I still ask my other questions. So other questions I have are there biomarkers that correlate with neuropathic pain? Are there biomarkers that correlate with constipation? And then what I do is I say, okay, do those biomarkers maybe tie into OMT? And so by embedding that osteopathic aim into my research, along with non-osteopathic aims, it makes you more likely to get grant funding from multiple different directions. The other thing is the world is moving in an osteopathic direction, which I think is the first time in a while. So there's an opioid crisis. The NIH funding is clamoring for people to find out some non-pharmacologic measures because the opioid crisis continues to be a really big, impactful deal. And so there's more integrative medicine acceptance, there's more funding opportunities. And again, if you can hit from both the osteopathic as well as non-osteopathic aims, you'll really appeal to both sides of the court. So more perks for osteopathic research. So you should know your worth. So we're eligible for all the same research grants that our MD colleagues are, but also all these different osteopathic opportunities through the AOA, the AAO, you know, and really international organizations as well. And so you're eligible for more money. There's more opportunities than non-DOs. And so I've had a lot of non-DOs that want to work with me to try to also utilize those fundings. So there's travel funds, there's institutional funds, linking up with an osteopathic school as well. So myself at Indiana University, we don't have a DO program. And so I linked up with Marion and I'm able to use their resources as well. And it's a two-way street. I have their medical students rotate with me. I have their medical students involved in projects. And I think that that's something really important, is by involving medical students and trainees and even fellows early on, you teach them OMT is important, it is impactful, and it's needed. And not just good osteopathic, but research osteopathic is needed. So, you know, it's not enough to do it, it's enough to do it in a systematic way that then we can translate into really solid research. These are a few of the grant mechanisms that I've utilized. So the LBORC through the AAO and then the American Osteopathic Association, they have medical student grants, trainee grants, new investigator grants, and they're all looking for similar projects like this. And again, by embedding that osteopathic aim, you really separate yourself out. And again, by bringing in trainees, you're training the next generation to do really good OMT research. And then, as mentioned before, the NIH is a really well-utilized oiled machine, but they're looking for non-pharmacologic interventions. And so there's actually a HEAL initiative out. And what that does is it's actually looking for any reason to fund someone to stop the opioid crisis. And so in my mind, what a great opportunity for DOs to start tapping into that funding and start to actually put on paper, OMT is safe, it is feasible, and it's effective, but we just need to get it in the literature. And so I'm happy to always answer any questions or share any of my research or resources with anyone. And I wanted to leave plenty of time for questions and discussion. So I will stop there and take any questions or any other thoughts. Thank you so much for your time.
Thank you, Dr. Belsky.
Thank you, Dr. Belsky. So just a few reminders before we open up discussion. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. And we ask that you briefly introduce yourself, and then please feel free to turn on your camera if you would like. When contributing to the discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. And we will provide you note cards, flashcards, letting you know how much time is left. And then as moderators, we'll be happy to read any questions or comments that you leave in the chat for Dr. Belsky. Does anybody have any questions at this time? Dr. Belsky, we have some comments that this was a really great talk. Okay, Dr. Lennart, we're gonna start with you.
Okay, thanks. Yeah, great talk. I'm Charles Lennart, osteopathic physician in Fitchburg, Massachusetts, and I'm a osteopathic recognition director at this residency program in the one in Worcester with UMass. One thing I put myself out. I participated when I was in Kirksville with DO-Touch.NET, and then I haven't really done much since I've been here for the last 6.5 years. But getting into a project, even a pilot, even a case study, I feel like I potentially should be farther along in how to do this, but I think I need a mentor. And just even somebody to follow up with, like, next step and to get this done. Even as I'm in my career midway, or not midway, early on, still a long way to go. But what do you think about that as far as being able to collaborate for just having a mentor for so many of these docs who are utilizing OMT but just not getting to the point of even a case presentation, case study or pilot.
Yeah, it's a great question. And I will tell you, that's actually the #1 question I get when I present is, I don't do research, and there's no reason for you to know how to appropriately do a case report, just like it would be the same as if I only practiced OMT. And so we're working on trying to get a good network of mentors to start even, helping out with case reports. I do a lot of editing and trying to guide folks with case reports as well. But I agree, it's one of the areas that the DO community, you're either headstrong into research and doing randomized controlled trials, or you're doing the clinician piece, which is actually doing the OMT portion. And so there are some mentorship opportunities through the AOA where they actually link you with a senior mentor. And I'm also happy to link you with some as well. But it definitely, if you don't write case reports all the time, it's a skill that is rarely taught in medical school that you lose really easily.
Thank you,
very
Dr.
much.
Belsky.
Yeah, I have to stay with the, if I get into it, then who I'm teaching to, I'm a part of UNE, their 3rd and 4th year education, and so anyway, I'd love to include that in theirs as well. So, but I need to learn first.
Yeah, no, and absolutely. And, the earlier we engage residents and, even just doing case reports with our residents and our medical students, it really spurs them on to think, hey, this is maybe something I can continue on. So I absolutely encourage that.
Thank you.
Dr. Downs, did you have a question?
Yeah, question, comment, I guess. So I'm US trained MD, Canadian trained osteopath. And for my Canadian degree, I was supposed to do a thesis. Okay, so I developed a research protocol and so forth. I was going to look at opioid-dependent chronic pain patients, treat them 4 or 5 times, and see if what impact it had in terms of their medication usage. My problem was I'm an office-based private practice. I could not get IRB approval anyhow, in any way, shape, or form. I spent $3,000 or $4,000 trying to get IRB approval, and the independent IRBs were only used to doing pharmacologic studies, and I could not get them to understand what I was trying to do. So that's one comment. Second comment is, if you have come up with anything to help with chemotherapy-induced neuropathic pain, let me know, because if somebody doesn't have an entrapment, I don't know how to help them, because I think it's just basically an end organ damage kind of problem. All right, thank you.
Yeah, the IRB, man, I've lost a lot of grief over the IRB. You're absolutely right. And in my opinion, the IRBs are not going to support. I luckily fought really hard and I was able to get my projects through the Indiana and Ohio State IRB, but you're right, it's an absolute challenge. And majority of the time it's because there's no literature on it. And so it's kind of this rabbit hole of, they're not going to accept us until we're doing this great research and say, okay, this is safe, this is feasible, you understand what it is, but it's hard without that IRB approval. So I absolutely share in your pain. The IRB process is almost impossible.
Until somebody does it, until it becomes easier, it is not worth the fight, no matter how important it is. I mean, because I spent, 6 months and gave up. So.
Yeah, and I think a lot of that can stem from retrospective studies, right? And so I think that there's a lot that can be said, doing research the right way is important, but also if you're doing these regular techniques in your clinic, there's no reason that you can't retrospectively go back and get that data. And I have had a lot better luck getting IRB exemption with retrospective data that can at least start laying the groundwork to say, hey, we went back retrospectively and looked at this, and this is safe and feasible. Now we want to design the prospective. And so I would encourage that too. Case reports, things like that don't necessarily need IRB approval at most institutions. A lot of them are exempt. So that's one way that I've gotten around a lot of it, is kind of just retrospectively and retroactively going back.
That's a really good idea, Dr. Belsky. Okay, so we have a lot of comments happening in the chat, and then we have a lot of hands raised. And just so everybody knows, I'm trying to take them in order. Yes, Jane?
Can I make a quick comment about the IRB?
Yes.
Another option is to see if you can get some sort of collaboration going with a researcher at an institution that has an OMM friendly IRB. So
Yes, absolutely. And that really goes back into that IRBs get nervous when it's an all osteopathic research. So if you can link on to someone that has biomarkers or someone that's doing something that they get and you sneak the OMT part in there, it's less scary to them than looking at an entire OMT protocol. So I tend to sneak in my osteopathic aims under folks that have been more successful than me. And it's slowly working, I think.
Okay, so we're going to move on to the next question. So Dr. Degenhart asked a question in the chat. In your research, were your interventions protocol driven?
My interventions are protocol driven, and I feel extremely strongly on this. And I may get some haters to this, but I'm used to it. So, it hurts my soul because as a DO and as an osteopath, I want to treat what I find, and I know that every patient is different. But the definition of scientific rigor is having a reproducible study. And so I feel very strongly that until we can get this, off the ground and show that our techniques are effective, I do everything with a protocol, and actually everything is checked off. So whoever's doing the OMT training actually goes through a validated check process. And so if we're doing a suboccipital release, everyone's doing it for the exact same amount of time, and they're doing it the same way with the same pressure. And I typically will not do more than 4 or 5 techniques, only because of time and feasibility, because I want to just prove that I should be able to get someone down from an 80% to 20%. But if I can just demonstrate now getting them down by 20%, I think that that's enough. And so as a DO, it does kill my soul a little bit to not be able to treat what I find. But as a researcher, I feel very strongly that you have to have a standardized protocol for this.
Dr. Degenhart, did you want to speak to that at all?
No, we'll have more discussion on that. Well, I'll stay in order. You can go ahead and get going next.
Thank you. Okay, Dr. Brooks also had a question.
So Jennifer, we haven't met. I've been practicing for 41 years. One of my primary mentors was Robert Fulford, so he focused on pediatric patients. So I hope maybe we can meet and you might be interested in my experiences in the future. I take care of adult chronic pain patients. But first of all, I want to say that I kneel down and worship to you and all your colleagues who are willing to take care of kids with cancer. That just is an awesome commitment. Are you familiar with the journal Cureus, C-U-R-E-U-S?
I am.
Okay, because that could potentially be a huge resource for building up big data with case presentations. I also wanted to make a little comment that it's sort of tangential to your talk, but I think one of the things that is very, very frequently overlooked is the role of constipation in lumbar pain syndromes, or potentially somatic dysfunction systemically, because there may be relative hypomagnesia as a common denominator. But specifically, so you get kids with back pain, and they, even though they may move their bowels every day, they can be full of you know what. And that's just a comment for people in general. My experience is it's overlooked. And so a plain film of the abdomen sometimes is very instructive in that regard.
Yeah, absolutely. And for my patients, constipation to me is so frustrating in my patients, because it should be a clinical diagnosis that, shouldn't necessarily require a whole lot, but our patients, who knows if they have tephlitis, if they have an appy, they're neutropenic. And so I end up getting way more imaging than is probably necessary. And 90% of the time it's constipation, but we can't miss that 10% of the time where it's something else. So those are great thoughts. I really appreciate it. I look forward to meeting you as well.
Okay, Dr. Belsky, we have a question from Dr. Amy Dean. She asks, how do you begin to incorporate residents and fellows into research projects?
Yeah, great question. Very slowly. So being that resident that came in and I said, I'm going to prove that OMT works. And here I am, I don't know, 12 years later that I still have very far to go to prove that. So, you know, getting residencies together to do projects together has been really successful in the past. So for example, the needs assessment, we had residents that each took a little part of it. And that was a great way to kind of involve them. And, you know, I think promising them up front and saying, you know, what's important to you? Do you want to learn the research methodology? Do you want to learn the OMT aspect? And kind of harnessing that large group. And then they have this really cool project. And so a lot of residents are busy, but they have these little OMT months. And so what we did is we actually blocked off 2 weeks to do a mini research rotation for them. And then we had this really cool project at the end that they were really proud of, that we actually were able to support at the hospital level too, to say, hey, our residents, A, they're interested enough to do a research project. B, it was a small research project, but really impactful. And C, we were able to get it done because we had a good timeline and we adequately divided things up. And so rather than launching them into, you know, hey, I want you to write up, even if it's a case report, or hey, I want you to do this, try to think of a collaborative project that they can all do together and share that workload. I found that to be a little bit more helpful than just the one student that says that they're going to do a project in residency, which we all know is pretty much impossible to get done.
Okay, Dr. Dagenhart,
Right,
it's your
great,
turn.
thanks. All right, so in regards to you know, building the research culture within osteopathic medicine, that's what we're kind of talking about right now. First of all, you know, I would just like to shout out to Jenny and people of her kind of era that broke into major MD residency and fellowships, who as a result were able to get that mentorship through their residency program, and they are becoming truly the leaders for this field in research. So first of all, it is very hard to do it on your own. I can say I've experienced that, and it's having a mentor is so important. And so having people who have been through that, like Jenny and others that are coming along, I think is going to really allow us to make the leap that we've been trying to do as a profession for some time. Now, I can say that within the AT Still Research Institute, we've done a variety of things to try to help with this process. So first of all, for those that are in residency programs and so forth, know that we have an annual meeting that is a national meeting. It has an online component, so you can be from anywhere to present your work as residents in a very positive mentoring type of experience. That happens November on an annual basis, and we are getting more and more residency programs to participate in this. Part of it is it provides some mentorship for people in who are running the residencies, because once again, they've not had this background. We are recommending that before people actually graduate from medical school, that they've already jumped through the case presentation hoop. Case presentations are, you know, while they can be interesting, they really rarely make a scientific impact. So when we're looking at then transitioning a student into a resident, it's really important. I think Jennifer's experienced this, where the whole residency team sees research as a continuum, not that you start it from scratch and you finish it on your own. That is a sure sign of disaster, and that's why we as a profession have not been able to succeed. So we got to redefine the process as one that is a continuum, that people take small projects around a consistent theme and build that over time. And that's going to be the recipe for success.
Yeah, I absolutely agree. And I had wonderful mentors that, and I think it's important too that our trainees know that you don't need a mentor to believe in the osteopathic part. You need a mentor that believes in them, because all research, I had mentors that were research trained. They had no idea about the OMM part, but that was my expertise. And so I had hematologists and oncologists that believed in what I could do, and they taught me the research part. And so I think that, people think that I sit a little bit on this pedestal and that I'm the only one that can mentor this osteopathic research. But in general, you just got to find a good researcher who's invested. And then the OMT part's not hard, right? We do that all the time. That's not the hard part. It's the, how can I scientifically make this possible? That's the challenging part.
Yeah, correct. Absolutely.
Okay,
And
Dr. Belsky,
I didn't say, Dr. Downs, I see your comment. It does kill my soul to have to treat them on a protocol. And then once they're done and off of my study, then I treat them normally. But I completely agree. I just separate out researcher and osteopath a lot of the time. And it's very difficult when I'm treating these kids on protocol. I literally have to like slap my hands to not fix something else that I feel. So it is a challenge.
Yeah.
Dr. Marcucci, did you have a question?
Not really. Do you hear me?
Yes.
Okay. No, first I wanted to present my congratulations to Dr. Belsky for her fantastic presentation. And what is fantastic, she presented something for kids, which is very, has an ethics issue important to do studies about children. But in the same time, she's doing what we should do also for adult, improving more our device, which is our hands. Do you hear me?
Yeah, we can hear you.
Well, what our hands are to do OMT, to treat patients. And for the moment, we don't have done enough science, bring enough science in osteopathic medicine to prove the efficiency and efficacy of osteopathic medicine. And therefore, we risk, if we don't do our borderline from the other manual therapies to be involved, osteopathic medicine will be mixed with other techniques, manual techniques, and will lose her specificity as we are practicing osteopathic medicine. So what I mean is, it is important to, and I'm thankful to DO-Touch.NET to boost the osteopathic research, which is very needful, because otherwise, if we will stand with the knowledge from Dr. Steele. Okay, I spoke too much. That's my Italian problem. I'm so sorry.
No, you make a great point, and I talk to adult providers all the time. You guys are already doing way more OMT than I have ever done. It's just looking back and doing it in a systematic way to be able to write it up.
Yes.
And, we have EMRs now. So, the chances, and Dr. Degenhardt, I know, has done a recent study, even looking at the literature of what are you guys treating? What are you seeing the most of? He just published that. And so, the time is right for publication, You just have to do it the right way. So I absolutely agree, and I appreciate it.
Thank you.
Dr. Brooks, did you have a comment or question?
Yeah, so I'd like to make a suggestion. It resonates with my life's work, which has been colored by the population I've dealt with, which is adult complex pain patients. But I think the fundamental insight is perhaps applicable, which is more than one of us have expressed the frustration of having to do protocol-based research. So what if we switch the protocol from a therapeutic protocol to a diagnostic protocol? What if we said there are X number of things you have to diagnose on a body, 5, 52, whatever we decide, and you have to examine those. And then you decide which one of those based on certain criteria, the historic, key lesion or whatever language you want to use, primary dysfunction, is where the therapy is addressed. And I think that might be a way to standardize the process and yet be true to that larger osteopathic experience and philosophy. So big idea, switching from a treatment protocol to a diagnostic protocol is something I just want to, put out there for you to think about.
Yeah, I absolutely agree. And I had started this whole journey thinking that was going to be a great road to go down. And I'll tell you, within the DO world, I completely agree. I think that's the way to do it. I run into a lot of challenges in the oncology world because my colleagues don't know how to diagnose. They don't know when I say somatic dysfunction, and they stop listening. And so it's frustrating because I completely agree. But when you take off your osteopathic hat and say, okay, I treated doing this, it resonates a little bit more with them. When I try to explain how I diagnose patients, and maybe it's my explanation of it, but they don't have that background of training to understand what goes into actually diagnosing. And I will say they barely understand when I explain to them how I'm treating. And so I think it's almost a backwards approach of once we can prove this part, then the diagnosis part. I agree of saying, okay, you've identified 3 out of the 5 areas. This would be where I would go. I absolutely agree.
So I've spent a good portion of my career working in allopathic institutions, and I have found that a shift in thinking and language resonates with their world. And as Brian and a couple others on the group know, my book on this subject will be out within weeks, if not days. And the shift is to shift from the postural structural model to a motion model. When you start talking with the MDs about restoring optimal motion and get away from positional language and alignment language, all of a sudden their eyes open up. They're like, oh, that makes sense. And so if you talk to any orthopod about restoring optimal motion, they go, well, of course. You talk to any orthopod about aligning anything, they go, that doesn't make any sense. So in any event, that's something, again, I'd be happy to discuss with you in more detail. And at the risk of being a little self-promoting, I'd encourage you to take a look at my book in the near future, because I think, in fact, the forward to my book is written by a professor of an MD, professor of pediatrics and neurology. And we just simply have to we have to break out of some of our dogmas and some of our jargon and find the common ground that resonates with the MD world. And all of a sudden, their attitude shifts fundamentally.
That's so interesting. Yeah, I look forward to reading that. That is definitely one of my communication in general, I think, is really challenging. And I'm really happy to hear that you're tackling that, because I agree a lot gets lost in translation to our MD colleagues. So I would love to chat more offline about that. I think that's really interesting and could change the approach for sure.
Dr. Degenhart, did you have a comment?
I do. Yeah, so when we did the MOPSI study, so the multi-center study on pneumonia in the elderly, we had a primary protocol-driven intervention. And so we also had like 81 treatment providers in that study. And so you talked about, looking at treatment duration, treatment forces, various components to not just performing a particular technique, but how that technique is performed. I'd like your comments on, one, how far you've been able to advance that level of standardization. And I would just like to give a little more perspective about our experience based off of your comments.
Yeah, so we're really fortunate here. We actually have, and I'm not sure how many osteopathic schools everyone works with, but we have actual model that we use first and second year that actually goes into how much pressure. And so it's actually training-based technology on a model. And so they have a spinal cord, and we'll say we're doing rib raising. It actually is all electronic. And so the student or whoever will do the rib raising, and then it gets real-time feedback and saying, okay, the goal is a 3 out of 10 deep pressure. So it gives them that feedback right away. And then there's a timer at the top. And so they have to do that, and they have to do it 5 times in a row to demonstrate that they're using the same pressure and the same protocol. And that's how they get checked off. And then they have to actually keep that up monthly for each technique that's in the protocol.
So from a clinician's perspective, forces applied may be different depending upon the body habitus of the individual. So how is that a consideration in your model?
Yeah, the best that we've been able to do is just validate it with the technology part. And to be honest, it more is to appease non-DOs that don't understand what that looks like. And we haven't had a whole lot of pushback when we've gone to publish. I think as long as we've had that some sort of validation, whether it's through technology or they're being checked off by a OMT professor, we haven't run into a whole lot of problems. But I agree, that's as close as we've been able to get to a perfect standardization or validation, but there's still definitely, you could slam it in the literature if you really wanted to.
No, I think your point is absolutely correct. Just for people within that scientific community see that it was done, that the process is being done, raises their sense of the rigor of the study. And so that's an important hoop that we need to certainly consider. And this certainly is going to be part of our discussion at our annual meeting before the convocation, talking about how we look at the techniques that we do and how are we using language that helps us know that what we're doing is similar to other people. Because right now the evidence, the literature would indicate that what we are doing is very independent of one provider to another provider. And it makes it very difficult then to determine the meaning of outcomes. I think this is a really important issue that we as a practice-based research network need to take ownership of and continue to work on.
Yeah, I agree. And I'll say something else that'll probably make me an unpopular candidate in this group, but there's something to be said about simple techniques. And I think that it resonates easier with people using simple techniques rather than cranial and, rather than things that people can't necessarily feel as well. And so I try really hard to stick with simple techniques that I feel like my fellow oncologists can understand. And for me, I've had a lot of difficulties explaining cranial to someone, just like Dr. Danza put in here, not believing what they haven't felt. And so until I can show that these easy techniques, like a suboccipital release can work, I'm kind of starting with that low-hanging fruit that you learned first and second year of medical school before jumping into only a handful of DOs in the state can do this feasibly. That's not super helpful to my patients. And so I try really hard to stick with the easy techniques. And someday I really want to translate those into home techniques to show that some home OMT, some simple techniques you can do for constipation, things like that, we can teach some families to do. So that's kind of on the back of my horizon as well.
Going off of your comment, one of the, we have a working group of DOs that are part of the International Consortium on Manual Therapies, and this is a newly forming organization trying to build interprofessional collaboration in a scientific manner to promote better patient outcomes. And our language as a profession isolates us from the basic science and the traditional scientific approach. And so especially when you start looking at cranial and visceral and a variety of techniques, that stuff just goes, that's just not, they can't even comprehend what we're talking about. And so this group has worked pretty hard in critically evaluating our language and looking at language that is going to translate into the basic sciences. And so that's something that's going to be coming down the road at their future conference and in their publications afterwards. So we're trying to address those issues because once again, if you can't communicate, if it doesn't make sense, and if it's so far out of their their consciousness, you're never going to get funded and you'll never get IRB approval. That's just the way it is.
Yep, I agree.
Okay, so I'm going to cut everybody off. We've run out of time. So just so you guys know what's coming up, next month we will have our journal club with Dr. Thomas Hoagie and Dr. Brian Dagenhart, who will be talking about the journal Osteopathy and Mental Health, an Embodied Predictive and Interceptive Framework, which is March 18th at 12 p.m. U.S. Central Time. Thank you guys all so much for joining us today. This was a really great presentation. Thank you so much, Dr. Belsky, for joining us and giving us this presentation. It was really, really wonderful.
Sarah, can you also make a mention about the annual meeting just to make sure?
Yeah, so our annual meeting is March 23rd. It will be from 7:30 to 12 in Florida, in Orlando, Florida, at the Rose and Shingle Creek. You can register for the meeting on our website, DO-Touch.NET. It is also being offered virtually, and it is 4 AOA credits for you guys. And there is a whole schedule listed on our website, and we really hope that you guys attend and join us that day. It's going to be a really great presentation. Thank you all so much.
Thank you, Jenny.